Thank you to everyone for joining Sepsis Canada's webinar and update. This webinar is primarily designed to be as a fill-in for our scientific meeting that we normally have every year. This is just to give you an update of all the work that has been done, a high-level update with some of the team leads that are present, giving a brief outline of what they've accomplished and how their projects are moving along, and a little bit of open discussion at the end. So as we get started, I'm going to pass the floor on to Osama for some land acknowledgements first.
Thank you very much, Saad. So recognizing and paying respect to the First Peoples on whose territory we live, work, and study is a vital part of our ongoing commitment to truth and reconciliation. And it's for this reason that a land acknowledgement is used at formal meetings like this one, at events and publications and in other university venues and settings as appropriate. Dalhousie University, where I work, operates in the unceded territories of the Mi'kmaq, Wolastoqey, and Pescatawagati peoples. These sovereign nations hold inherent rights as the original peoples of the lands, and we each carry collective obligations under the peace and friendship treaties. We are all treaty people. In addition, McMaster University, where a lot of the work of Sepsis Canada happens, recognizes and acknowledges that it is located on the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement, an agreement to peacefully share and care for the resources around the Grand Lakes. As we spend some time today thinking about the future of Sepsis Canada and sepsis research more broadly, we hope this will also be an opportunity to discuss how to meaningfully embed key tenets of truth and reconciliation in the work we do, including building relationships with Indigenous peoples and supporting sepsis research from communities and nations. Thanks, Saad.
Thank you, Osama. So moving on to the webinar objectives. To let the attendees know that Sepsis Canada has reached its 2/3 landmark of the grant operation, meaning we have about a third left of the grant cycle before it comes to a conclusion. We want to use this opportunity to provide everyone an update, a brief overview of what the network has accomplished thus far, some project highlights as we move along, and then the last bit will have an open discussion into some of the network initiatives and directions. The presenters today are myself, Sasanina Osama, which you've heard, and also Dr. Alison Foster-Bishop. Really quickly, if anything, this is an executive summary of what the talk is going to be about. We have about 278 members across the country, a couple of international members, as well as 31 patient partners who play an integral role in the network. Thus far, we have about 32 publications that have been accepted. 69, as probably over 69 presentations and talks that have been given by Sepsis Canada research projects members, and as well as 71 trainees in our training program. Going on to provide you high-level network project updates, I'm going to pass it on to Dr. Foster-Bishop. Austin.
Unmute myself. There we go. Good afternoon, everybody. We thought that this was, as we finish sort of sepsis month and a couple of weeks past World Sepsis Day events, an opportunity to talk about what the network's been doing. Just to reframe the people on the audience, when we created the original grant, we had 3 teams with an overarching vision of suspect sepsis, save lives, and support recovery. We're going to run through each of these teams, the population health economics and policy, talk about where we're going with some of the policy work, the advocacy, knowledge transfer and education, and the translational biology clinical trials and rehab group. Next slide, please. So the population health team really has been working on 4 different areas. And if Saad brings them all forward, I'm actually going to start with the last one first. really one of the things that were asked was some of the risk factors, and we particularly focused the projects on the risk factors for diabetes, partly because of the funding that we receive from the Institute of Circulatory, or the Institute of Metabolism and Diabetes. And I think there are two huge take-home messages out of that. The first is the event rate for sepsis survivors for subsequent cardiovascular disease increased in those people who are diabetic, who get septic, and that the short-term risk for developing sepsis is no greater in people who are diabetic than they are non-diabetic. We've been continuing to work on diagnostic codes and refining the sepsis code at 3-site project. I had a recent update from that. And we are working on a project in Alberta looking at machine learning clusters for phenotypes of sepsis that is nearly ready to apply into hospitals. So for those of you who are interested in Epic hospitals, but also I think particularly NALI could do other hospitals, we can do that. We now have a broad metadata catalog for population health researchers to look at in terms of using that to ask additional questions about patient populations that might be at risk of sepsis. And one of the things that Alan Garland and that group have been doing is trying to find additional projects for it. So if anybody wants to take that on, that's a great one. And finally, we have a scoping review that I hear is nearing completion that will look at the population health of, from a population health perspective of areas around sepsis particularly. I'm going to let Callie, if she's not had run off, talk a little bit about the paper that has just been accepted in critical care on the social determinants and costs of sepsis. Callie.
Sure. I'm going to share my screen here.
I have to stop sharing for a second, so.
I hate Teams. It's not letting me share. Hey, Fatima, can you pull it up and share your screen?
I have to give Fatima sharing privileges.
Or do I need sharing privileges? Is that the issue?
You should have sharing privileges, Callie. And then if you just share your screen, if you have it up already, as opposed to the file. Maybe while Callie's coming up, I'll talk about trying to get this up. And I don't know if Saad, you've given Fatima sharing privileges. Oh, look.
Okay, can you see it now? There we go.
can see it now. There we
Okay.
go. It's
all right.
Flashing through.
So
there we go.
I am going to specifically speak to the Project 5 update. So this is all from the website, but as Allison mentioned, I'm situated here within this Team 1 group, specifically looking at the economic costs of sepsis. And then sort of where this landed was within improving the detection and identification of sepsis a little bit, and more so actually some of the causes of sepsis from a social determinants of health issue. So specifically, Project 5 was to assess the economic consequences of sepsis and to inform policy development and health economic evaluation. So it's evidence to inform policy. So initially, our aim was to further our understanding of the economic impacts of sepsis from both the health system and the societal perspective. And we were going to look at the effects of sepsis specifically on the risk of becoming a new high-cost user to the health system and estimate how social determinants of health, as indicated by marginalization, modify that effect. That's the work that I'm going to specifically talk about. We'd also hoped to do some work on the effects of sepsis on the ability to work and earn, and that project has sort of been parked, and I'm no longer a part of that project. And there was real tangible sort of work or sort of knowledge translation applications of this work that they'd have immediate and really tangible applicability, and that they'd inform health economic evaluations of things like rapid diagnostic tests or social vaccination strategies. We'd really be able to get sort of that long-term cost profile that's very often missing in health economic evaluations, and also to inform policy development related to sepsis. So with respect to the economics team, the affiliated projects that we've worked on, just want to say that we put together an absolutely amazing team. So I really want to highlight here Fatima, who has been unbelievable, and this superstar here, so Victoria Cecilina. So this woman you're going to hear and see in the future. She's a third year undergrad student at Western, absolutely brilliant. And it has been an absolute pleasure to mentor her. So she is certainly a de facto Sepsis Canada member. In terms of senior scientists working on this project with me, Ked, Peter Dodek, Damon Scales, and Laura Rosella. Laura is probably one of the most senior and well-versed scientists in Ontario respect to using ICS data and cost. And Hannah Chung was our analyst at ICS, who was very involved in developing the methodology. She's moved on to the Ministry of Health, and we're waiting to get a new analyst at ICS, but she really also deserves a lot of credit here. So the first thing we did was we actually had to develop new methods to answer our question. So we knew how to identify the high cost threshold. So if you were in the province of Ontario and your healthcare costs were just under $800 in 2014, you would have been a top 5% high cost user. And so we calculated costs for every individual in the province over each calendar month and identified the thresholds. But then we had this problem where it doesn't really work when you're using high cost user status as a time varying covariate. And we had difficulty with incomplete observation time, sometimes right censoring. So we had to identify a new method to account for all of this. So we spent quite a number of time. I'm not going to get into the details because it's actually quite complicated, but we developed methods and sort of tested them in terms of sensitivity testing and identified a method that was the most specific at identifying high cost users. So we've presented that work at the CDA AMC, formerly known as CADIF, their conference in September, and we're hoping to submit a manuscript for this work in the next 6 to 8 weeks. Then there's this paper that is actually been accepted, and I'm reviewing the proofs right now, which is the impact of sepsis on becoming a new high-cost user. So for this project, what we did was we created a cohort of individuals who've been hospitalized in Ontario from 2014 to 2016. And we we didn't match. We calculated the propensity score for everyone in the cohort and then used IPTW weighting to weight the cohort so that there was balance of all the baseline covariates. What I'm showing you here is actually after weighting. So the only thing different between these two groups, the weighted sepsis and the weighted non-sepsis, is that the weighted sepsis group had sepsis identified during their hospitalization and the weighted non-sepsis did not. So they have the same, they're from the same socioeconomic background, they had the same comorbidity profile, like all of those sort of known predictors of future healthcare resource utilization were normalized, which you would also assume are going to be predictors of healthcare use. And so this predicted what we knew it would. Like this makes no sense, makes total sense for all of us in the room who know sepsis, but individuals who had a hospitalization with sepsis, they had a longer length of stay, they were more likely to be admitted to the ICU, their ICU stay was more longer, they were more likely to receive mechanical ventilation, and their cost of that hospitalization itself was significantly higher. So this really speaks to the impact of sepsis in terms of a health system resource utilization, the impact. When we used that total weighted cohort and we created an outcome of being a top 5% high cost user for any 3 30-day intervals, so a cumulative 90 days at any point after discharge from hospital, the individuals who had sepsis were more likely, odds ratio of 1.73. We decided to also look at the proportion of their follow-up time that they were a high cost user. And so they spent twice as much time, when they were top 1%, almost twice as much time with the risk rate of 1.46. Then we looked at those people who were the highest of the high cost users. So these were people who were at the 99th percentile for 3 months, at least consecutively. And there was an odds ratio of, were 2 times more likely to have that with an odds ratio of 2.05. That was statistically significant. And they spent also statistically significant more time as a high-cost user. They spend on average 18.5% of their follow-up time at the 99th percentile for the population of Ontario as a high-cost user. So pretty significant results. But what we also need to remember is that this cohort included all individuals who were hospitalized in Ontario over a given period of time. And we know that individuals who are admitted to hospital are also likely to be sick and frail and have pre-existing conditions, which probably meant that they were high-cost users before they were hospitalized. So we stratified our cohort by individuals who had never been a previous high-cost user. So these were the young, healthy, fit people who had very little contact with the health system, if ever, and then they get sepsis and what happens to them. So after an episode of sepsis, their odds of becoming a high-cost user for at least 90 days after discharge are 2.24. They spend about 20% of their follow-up time as a high-cost user. And then when we look at what percentage, like what the proportion were that went into being a super high-cost user, so at the 99th percentile, or a top 1% high-cost user, and the odds ratio was almost 3. So they were almost 3 times more likely to be a top 1%. And they spent about 10% of their time as a top high-cost user. So we presented these results at the CASPR, which is the Canadian Agency for Health Services and Policy Research, that conference in May. And this paper has been accepted at Critical Care, and I'm reviewing proofs right now, so hopefully it'll be published shortly. We also, and this is where I want to talk about Victoria. So when it was clear that she had potential and she was really eager, we gave her an opportunity to take a project and be the PI on it. And she wanted to do a systematic review. So she's looking at what are the healthcare costs after sepsis. So really a really nice sort of buddy project to these high-cost users. So the high-cost user paper is putting it in the context of the overall healthcare spending. And then this paper is describing what are the patterns and sort of what do the costs look like for people who've been hospitalized and then after their hospitalization. And she's almost done, actually. And so we're expecting that manuscript will be ready for submission in about 6 to 8 weeks as well. So this is, I got to say, this has been like the greatest part of being involved in this network, is being able to mentor her. And she's applying in med school. So Allison, if you get her, review her package. She's amazing. She also scored in the 100th percentile on the MCAT. Okay, so then there's some work that we've done with the policy working group where these sort of were not part of what we originally proposed to do, but like they just sort of gelled and came together, and so we're doing them. So first is this jurisdictional scoping review, which I should not be here presenting because Fatima is actually leading this. So this was the protocol was published in January, but you'll see they received it in July. It took them a while to get it out there. But it's actually, we've got a sneak peek of the results. Fatima is going to share those at the Canadian Critical Care Forum in November. But really what these are going to demonstrate is that there is a huge gap of sepsis policies, and places where sepsis should exist don't, and places where there should be guidelines and standards for sepsis don't. So that paper is really to help justify why we need to be paying attention to sepsis. We also wrote this paper where we called for a national action plan on sepsis. So this stems from some work that Fatima had done earlier, where she analyzed some policy development in the context of this sort of policy analytic framework that's very common in the health policy world. And we sort of adapted that and then used it as a case study to then look at other policies that have been developed in Canada, where a sepsis death had occurred or sepsis deaths occurred, and then there was sort of this reactive policy that was developed. So examples were like when there were poor food handling policies and there were deaths from E. coli, then suddenly there was an attention towards how do we handle food safety, even cross-border. So in summary, in the last 12 months, we've been very productive. We've got 3 published manuscripts, 3 more papers that are going to be submitted by the end of the year, 4 oral presentations, and several posters. And our future projects, sort of within this little umbrella of projects, is we have analyses underway of the effect of sepsis on becoming a high-cost user using a non-hospitalized comparator group. So the effect will be even higher, I'm sure, because these will be comparator group of people living in the community as opposed to having come from a hospitalization. Some some very important work exploring the role of marginalization in that connection between sepsis and being a high-cost user. We're going to look at the effect of critical illness on becoming a high-cost user, and then have a subgroup of sepsis within that. And that's really to tease out the critical care effect of becoming a high-cost user. And then we also identified some really interesting patterns in the high-cost user thresholds during the COVID-19 pandemic. And so from a health economic perspective, this is going to be a very interesting analysis, because it will essentially demonstrate how allowing a pandemic or a pandemic developing, how it completely decimated normal healthcare spending, and how we completely had to shift to acute care spending, and actually the volumes of, or the absolute value of spending, how significantly high it was. So it kind of puts a really good health economic frame on what happened and the consequences of not being prepared and preventing these infections. And that's where I end. So I'll leave it at that.
Thank you, Callie.
Thanks, Callie. It's a brilliant amount of work in a short period of time. For those of you who don't know pop health or health economics, Callie has been my coach on a steep learning curve and all of this along the way. And I'm grateful that she's been helping Fatima with some of her PhD work as well. Okay, the last thing on that slide was we are working on getting Chi-High data. It has been over a year in terms of getting some global pan-Canadian, or as pan-Canadian as we possibly can get for adults. We still have a problem on the pediatric side. We can talk about that at the end, but we are working on getting Chi-High data for all codes of sepsis, and what's publicly reported is really the in-hospital sepsis. We don't have the full picture without the full Chi-High pattern. So CADNAP is leading that project. Next slide. I don't see Alex on SAD. Okay, so the paramedics and ED side of the protocol in terms of sepsis awareness, they worked on a systematic review. Protocol was published. They have a paper ready to go. They have a survey and both a more of a quantitative survey, qualitative survey, and then focus groups. And those two papers are nearly publication and ready to go to the Annals of Emergency Medicine. The editor-in-chief has reached out to Alex and Blair to publish that. On the public side, we've now got the scoping review that was published in terms of knowledge, the Canadian survey, which we've talked about before in terms of the fact that clearly about 40% of Canadians had not heard of sepsis, and many of them don't recognize that vaccines are part of the preventative strategy. That team has been working hard on focus groups and a toolbox, mnemonic aids, and recently submitted a CIHR project grant to continue some of this education work. Gina Parsons-Lee is partnering with Shoppers Drug Mart in Nova Scotia to try and work on an education focus within pharmacies. Next slide. I think I'll hand it over to Osama to talk about the education.
Thanks very much, Alison. So obviously education is a key pillar of the Sepsis Canada network. The Lifting and Sepsis Canada program were created to meet these goals. They offer a unique health research training opportunity that's meant for clinicians, researchers, patients, and family partners that are interested in sepsis. The format is also unique. The delivery format is structured to accommodate participants who work full-time with an emphasis on individualized learning through mentorship. The curriculum is designed with the core principles of breaking silos, personalized training, and promoting equity and diversity in sepsis research and care. And to facilitate this, the content is delivered through several methods. It's delivered through online modules, workshops and fireside chats, mentorship pods, practicums, which is where trainees are funded up to $2,000 to take part in an experiential research/learning opportunity of their choice, and an annual in-person symposium. The program's been extremely successful, with 30 trainees already graduated, 33 having completed their first year and 46 starting this year. And as you can see in the pie chart here, the trainees come from all sorts of different backgrounds, including family partners that make up a significant portion of the trainees. Sepsis Canada also provides trainee awards annually of $25,000 to one trainee proposal per Sepsis Canada research stream. Last year, this award went to two recipients, Jenna Smith Turchin and Ashraf Karat. And this year, the awards have been given to Foro Johandita and Shelley Severson for their great work. The lifting team has done phenomenal work, and that's just not us saying that. Just this year, they were recognized by the Canadian Association for University Continuing Education. The lifting program, won awards for programming, particularly in partnership context. So this is, I mean, it's only 3 years now, and it's already being recognized at a national level. Also, this year was the first graduating class with 30 graduates completing the program. The graduates, as I mentioned before, came from a broad spectrum of backgrounds and are moving forward to a wide range of endeavors. So this is fantastic work that's been put together by the lifting team and is already, I think, making an impact and being recognized nationally.
And I must say, participating in that training program, to see even some of our most experienced research coordinators praising that program. I've never seen a graduating class crying because their 2-year program was over, but it was just amazing to be part of that group around the graduation ceremony. The Translational Biology Trial Infrastructure and Rehabilitation team, I want to highlight some of the work that's happening around the National Preclinical Sepsis Program. If you recall, this was taking clinical trials and moving it into real space. That team is right in the midst of after several pilot studies, publications associated with that, right in the middle. I think it's happening in November, if I remember the emails, where they're going to start their multi-center preclinical trial with a whole bunch of biobanking and outcome measures. Associated with that has been a really interesting project looking at how biomedical scientists collaborate together. And I see some of that group here and know that you've been interviewed with that. The research network, you will recall we've had a CMAJ paper about the research network and the need for this in the last year. Importantly, Francois and the team have been working on a health economics paper related to COVID and the appropriateness of drugs based on guidelines or not based on guidelines and the health economic impact of that. Callie's going to be helping to get that across the finish line in the next little while. And we still have the ongoing rehabilitation project, and hopefully by next year we'll have a huge update on that project as well in terms of some tools for measuring metrics around neurocognitive and motor skills at the end as a testing framework. Next slide. I think it's back to you, Saad.
Thanks, Alison. So the patient partners and the advisory council is a crucial component for us in Sepsis Canada. It's made up of patients, survivors, caregivers, and advocates. The council ensures that the lived experiences and perspectives of those that are directly affected by sepsis are at the heart of what we do. The council is co-chaired by 2 sepsis survivors, Christine Caron up top and Winona Ryder at the picture at the bottom there. So this council makes sure that we have patient partners collaborating with researchers, healthcare professionals, and policymakers. It plays an active role in helping to shape our research, forming our policy, and ultimately in improving sepsis care for sepsis survivors and their families. The council is made up of 31 members who meet quarterly, the main objective being to bring the perspectives of patients and families to research to make it relevant for those that go through and suffer with sepsis. Their insights and advocacy really are invaluable in driving forward the mission of Sepsis Canada to improve prevention, diagnosis, treatment, and long-term outcomes for everybody in Canada who's at risk or who's affected by sepsis. We do integrate patient partners in all of the research that we do and all of the research projects, and they really do play a large role in shaping advocacy efforts and ensuring a patient-centered direction. Also, Sepsis Canada supported a grant for patient partners research in sepsis that was held by the three people you see there, Christine Russell, Mary Maxime, and Dr. Marianne Veter. The grant basically was looking at characterizing the impact of engaging with patient advisory councils on long-term recovery for sepsis survivors and their families. They had had a chance to present their work in our inpatient symposium and have done fantastic work on their topic.
Thank you. So I guess it's my section here. A lot of work has been done, and aside from the publication that has been presented, we've done partnership grants with the Canadian Fertility Network, CMDO. We've again presented over 69 presentations by now and have a leveraged funding of over $11 million. So aside from these metrics, we've done other things to bring awareness to the public. Like we've had several publications in open access government. This is a publication that many government officials around the world tend to read. So we have 3 already being published there. Several articles that highlight what Sepsis Canada is doing, individuals within the group, and also how sepsis is affecting the general public. And many thanks to our communications coordinator, Alice, in order to reach out to the media and ensuring that these voices are being presented in the public forum. As Alison had mentioned, September is considered Sepsis Awareness Month, and on September 13th was World Sepsis Day. Through the efforts of many patient partners and other volunteers, we've managed to light up about 82 monuments and structures around the country purple, or pink, I should say. And there's a few examples of the hard work that has been going on behind the scenes to get these structures lit up, all part and parcel of raising sepsis awareness in the country. We've also reached out to all the parliaments across the country, and 5 provinces out of 10 had declared September 13 as September World Sepsis Day, and 2 out of the 3 territories as well. An example of these declarations are on the bottom there. Going to be talking a little bit more now on some of the network initiatives. I'll pass it on to Alison.
So many of you will have participated in a survey of Canadian researchers. I'll tell you a little while. That unique survey's taken a little while to get published, but we've resubmitted it recently to PLOS Global Health with the hope of getting accepted and published to describe to the world some of the sepsis research that's happening in the country. Callie's really highlighted eventually working towards a national action plan on sepsis, or Sepsis National Action Plan. We're going to call it SNAP maybe, and national policies. Fatima, you saw a picture of her back there, has published recently her CJA paper, and we had a bit of a media release, including the front page of the Hamilton Spectator, about social determinants, and will continue that work as part of her PhD. We talked briefly about the Kai-Hai data that's coming. I have an undergraduate student, and Barbara Dolajansky, who's one of the graduates from the training program, who are doing a massive scoping review with the help of a few other students, looking at what we teach or what is taught in K-12 healthcare education. And this year they're starting to work on an educational module focused at the middle school age, because that's where Barbara teaches, so that we can start to develop some school-based teaching programs. Sepsis and pediatrics, Ashraf's work on looking at neonatal sepsis is important. I think we need to really continue to work on pediatric sepsis. From my end at the leadership, I'm going to be going back to the Institute for Pediatric Care and saying, why are we not looking at sepsis research across the country from a pediatric lens? And hopefully to champion that along the way. But these are some of the other projects that were not on the original grant. Some of them cost a little bit of money. Some of them are being funded out of the background. And Callie, I'll let you answer. Put your hand up. You got your hand up for a question right now.
Yeah, I just think we need to be very clear in terms of when we're talking about a national sepsis action plan or SNAP, that a national action plan cannot be something that comes from Sepsis Canada. Sepsis Canada is a research network. It was never part of what we asked for when we asked for the money. And the role of policy within Sepsis Canada is to be a place where research that is related to policy can happen. But the policy development itself needs to come out of not at all affiliate, like not affiliated, but it cannot be generated by Sepsis Canada. Sepsis Canada is a research network, right? So I think instead of saying like national sepsis policy, I would rewrite that as ongoing research to support policy development. And the policy team that we're hoping to sort of pull together is really sort of like a subgroup of Team 1. And so the three teams, like the way I look at those three teams is one is like health services, research and policy. One of them is sort of like qualitative knowledge translation. And one of them is sort of like basic science and some translation of basic science, right? Like when you look at it in sort of those sort of like scientific buckets. And within health services, research and policy, there's the policy piece is what evidence do we need to generate to help decision makers make policy? And so I just want to make sure we're very clear on that, and that the role of like you, Allison, and Osama going forward with respect to a national action plan is you need funding for the Sepsis Canada network to continue to support that research work, but the policy development and sort of the work going on to develop a national action plan, that has to happen outside of the network. But Sepsis Canada is certainly going to be at the table helping with that work, because a national action plan involves ongoing research and innovation to ensure that we're like a national action plan we're not done then, right? Like there's going to be a need for ongoing research. So the purpose of Sepsis Canada can be the home for the ongoing evidence generation with respect to sepsis in Canada, but the policy development is going to be a much bigger piece than that. Just want to make that clear.
That's why I learned from Callie.
Thank you. And I think that, brings us nicely to the next section, which is talking about, it's an open discussion in terms of what the network is going to be doing and more about the sustainability aspect of it. And Allison, you can just briefly outline what sort of activities, aside from the initiatives, that may be in Sepsis Canada's sites.
So I think the first thing is that, they gave us, considering how much a trial costs or something else, a relatively modest pocket of money for which we have done a whole lot of work over the past 4.5 years. And with that money, we need to be able to sustain the great people who are behind the scenes. I have to champion Saad and Ellis and everybody else who keep the day-to-day operations of the network running. But we also know that this is the tip of the iceberg in terms of the projects. That means a couple of things. If you're working in a sepsis area, please, we didn't even acknowledge today the Grants and Manuscripts Committee. Consider that, we can make your grants stronger by being part of this network. And it's clear that other networks get funding because they've had a review of their grant, they've got a name on it, and they've built that brand a part of all of this. So I know there are scientists here who are continuing to do sepsis research. It's an opportunity to say we're building on the network, and this is the go-to place for sepsis research. The second piece of all of this is the project grants that you may go in. While CIHR is changing those letters of endorsement policies going forward, there's nothing to say that you can't say in that project grant that Sepsis Canada's Grants and Manuscripts Committee didn't have an oversight of this grant before it was submitted, and that you're a member of Sepsis Canada. The third thing that we're working on is really going to some of those other institutes. Saad and I and Osama have been talking in the background. We saw a meeting grant came out recently about whether we want to specifically and purposefully meet with Indigenous leaders in Vancouver to start to talk about our relationship as a disease-based research network and how we can work with Indigenous scientists and the Indigenous community to build that. And I know I saw Shannon on here somewhere. So one of those things in terms of how we can work with that community. The fourth mechanism is something that I started yesterday and which the Patient Council has been doing. We have been advocating that rather than running off of RFAs out of the network, we need some central core governmental funding. People call it ring fence funding sometimes. And we have been doing work along that way in terms of finding advocates. The Patient Council has written letters to the CIHR. Yesterday, I met with Senator Ravalia, who has really been a big proponent of sepsis at the House of Commons and within the government on Parliament Hill, and had a conversation. Christine and Caron and I had a conversation with him yesterday about the network, about the work we're doing, and having those people who listen to us is another piece of this advocacy for ongoing science work. There are other partnership opportunities, and I saw one come across for France recently in the EU. So if anybody's thinking about partnership grants, please let us know, because it's another way of amplifying the work that we're doing across the country. I think I'll leave it at there, Saad. And I'd love to open it up. If people have questions, put them in your chat Q&A, and then maybe we can we unmute people, Saad, too, who are in the audience if they want to speak instead? Okay.
Yeah.
Callie, you got your hand back up again.
So I was just looking at the CIHR website, and within the infection and immunity pillar, there are areas, or maybe it was, anyways, areas of interest or sort of focus areas. AMR is there, but sepsis is not. And I think that, an amazing thing that you guys could do would be advocating to CIHR that should be an initiative that they're focused on. And like that to me that's low hanging fruit. Get CIHR to recognize that this needs to have targeted sort of calls for proposals and calls for grants.
Yeah, the challenge, Kelly, and Saad and I have been dealing with this for 4 years plus, and I think Paul Koobs was dealing it before. When you go to that disease-based drop-down menu at CIHR, you can find stroke, you can find respiratory diseases, you can find any number of things, but you pull that down and you can't find sepsis. And it is a huge, huge, huge problem, which we have repeatedly come back to CIHR back. The last word I had heard, well, we're revising the grant application process and we can't change the drop-down menu. So we've continued that. We have a meeting in Toronto with the new director for the Institute for Circulatory and Respiratory Health. We've brought this up again to the associate director. We continue to advocate for that, but I don't disagree with you. I guess the last thing to highlight is the meeting in Toronto coming up, Critical Care Canada Forum. We will be jointly meeting with the antimicrobial resistance group. The partnership that we had for last year's meeting with BioMaru has been fruitful. CIHR is certainly encouraging us to have ethical relationships with industry. And this one has been very good for us in terms of both connections and the ability to link antimicrobial resistance and sepsis. So I get it, and let's continue. We are continuing that conversation. I have a piece coming out in CBC probably tomorrow on Second Opinion that Christine and somebody else spoke at about these links between AMR and sepsis. So hopefully that message will be heard. Fatima, you got your hand up, huh?
Oh, I can unmute now. Thanks for that, Saad. Sorry, I couldn't do it before when I was called on. Just really wanted to say two quick things. The first, I completely agree with comments from Callie around some of the policy work and that distinction. My question is really, I heard just towards the end here about the meeting in Vancouver and potentially looking to engage our Indigenous patient populations on this work. And so a few questions there. I know that the network has sort of put EDI as a pillar and what the strategies are around that, and whether or not this initiative will be Indigenous led, if it's something we've heard from communities as being important, or if it's something that's being led by the network. Just want to be cognizant of the issues that we put forward and how we sort of center those voices. And we look to researchers and communities to help guide us on that path. I think we haven't done a great job of that in sepsis and in critical care, but we certainly also have an opportunity to do it well and to learn from other areas that have done this better. So just wanted to put that thought out there to make sure that as a network, as we look to engage in this work, that we're centering the right voices and that we're approaching this in ways that are reflective of the communities.
Can we unmute Shannon for a minute? Shannon?
Yeah, she's has the ability to unmute.
Okay.
There we go. Hi there.
Hello. I wanted to give you an opportunity to answer Fatima's question about the with versus to the Indigenous community. And I've learned that distinction. I think we don't know. We'll have some data coming back from Gloria in terms of Manitoba and the sepsis risk in the next little while. She's taken that project on, Fatima's, but it's this two-way street, and I get that they have to come to us. But Shannon, I just want your opinion on that reach out versus they coming to us.
The conversation needs to start somewhere, and I believe that the First Nations chiefs and the different nations do not know the risk factor that sepsis is to their communities. So I think it's an opportunity for us to engage and teach. But then again, on the other side, they're wary of medical professionals for a reason. So it's a fine tightrope.
Thanks, Shannon. I completely appreciate that, both comments around, an opportunity to bring this forward and help center the conversation so that we can move the work forward, particularly when we know there's disproportionate risk, and we want to do better for everyone. And I completely appreciate that. And at the same time, want to acknowledge the power differentials and want to acknowledge that there's good reason for some of that hesitation. And certainly, I think we need to be careful around reporting disparities. And I say that cognizant of the fact that one of my more recent papers does report disparities, but we were careful to acknowledge why those disparities exist, right? It's not that certain individuals of a particular race or ethnicity are at increased risk because of the color of their skin, but really rather the systems that we're working in. So And not to say that this work isn't important, but I do want to make sure that as we think to embark on this journey, we're cognizant of our approach and we make sure to partner with the right people and in the right ways to ensure that this is something that we can continue and build momentum across the organization.
Yeah.
Thanks, Shannon.
I think
for,
Fatima,
your
we
comments.
just, Christine's got her hand up, but it's the start of a conversation. If we have a meeting, it's going to be a start of a conversation, right? And perhaps with some data and, you know, when I've had conversations with the Kings, for example, and others that you and I have had, you know, I think certain scientists within the community recognize the importance, but getting down to the leaders within communities may be a little different thing. Christine, you've got your hand up and you're unmuted now.
I just wanted to bring forward that the critical care trials group has a group called the Guidance Circle, and that is what they are there for, is to help connect the various groups. So I was just going to say, if this is the plan, you might consider involving Paula and her Guidance Circle.
Oh, no, Paula was the first person on our list we were going to reach out to.
I just wanted to make sure that because she's got a Guidance Circle going, and they're from across the country.
In Vancouver. So just for the audience, the World Congress of Intensive and Critical Care will be in Vancouver from the 16th to the 25th. The trials group will be there. Sepsis Canada is planning to be there. There will be other groups there. There will be a elder in residence, and the local organizing committee, as part of all of that, is really advocating for a large Indigenous presence. I can't steal all of the thunder what day one's going to look like, but it's going to have a huge focus on Indigenous health and critical illness. So there is an opportunity for us to align some of that work at the same time in Vancouver, and that's why I'm talking about this. We got 5 minutes left in our meeting, and Manoj has just turned on his camera. Do you have a question, Manoj?
No, I just wasn't available before then to talk, but I was listening in. Great summary.
Okay.
Thank you.
Any other questions for people?
Yeah. Thanks, Gally. Thanks, Fatima and Shannon and Christine for chiming in as well. Again, this is just a very quick update. I know it was a last minute thing trying to put the webinar together, so I apologize on the structure of it, but I think it gives a good idea of what the network has been doing thus far and some clues on the projects and their work. So if there's any other questions or points or thoughts that you would like to raise, please feel free, and you have about a minute and I will try to unmute you.
Christine, did you have another question? Your hand's still up.
No, sorry.
No, it's okay. If not, I think on behalf of Saad, Osama, Ellis, and the leadership team, I want to thank everybody who's joined. And for those who are going to hear this recording later, don't hesitate to reach out to us and ask us questions. You know, we have a lot of people in the network who were part of the original grant, but maybe haven't felt as engaged in some of the projects that were described in the grant. But it's an opportunity for us to connect and understand where you're going with sepsis research and where your priorities are and how they align with the network. So please take an opportunity to reach out to us.